Today we interview Michael Watts, CEO and co-founder of Blüm Health. Michael, welcome to our podcast.
Thanks for having me, Ignacio.
So, could you tell us about one first project regarding digital data AI that we can learn from?
Yeah, so I think we're working on a really exciting project at the moment that looks at processing discharge summaries. So whilst it's perhaps not the most sort of novel process, the utilization of AI really clearly demonstrates a return on investment for those that are using it, particularly in the UK National Health Service, the NHS. So essentially what we've done is we've built a solution that can ingest loads of discharge summaries. So when a patient leaves hospital, they have a letter written by the doctor to the primary care physician about the care that they received. And these are typically processed by secretaries, administrative staff, potentially tens, hundreds a day if it's a big practice. And that can be a very cost expensive, time expensive process. So by building out a model that allows us to read the discharge summary, code the summary, summarize the plan, and then also summarize the care that was received, we're able to more effectively manage the continuity of care, release those staff to do what they were hired to be doing, which is the secretarial and administrative job that they did first and foremost. And at the same time, the patient gets that continuity of care that is so important to whatever illness it was that they had that took them to hospital. So really quite a nice operational efficiency utilization of AI that we're seeing across the UK.
It is, and where is it running? In all the trusts or some pilot maybe?
So yeah, it's focused in primary care. We're actually partnering with an organization that does this process manually for GPs, believe it or not. So there are organizations out there that are doing this manual process as like an overflow service for these primary care practices. So they've actually said, we can automate this process, and we're actually working with them. So they've seen the problem firsthand. They've kind of said, there's no need for us to be doing this overflow process. Actually, bring technology in to service these organizations, and they'll save money, and it makes it a lot easier for everyone. So that's the idea. So we're in that kind of implementation phase for now, with the view to roll it out across. Well, they're servicing almost half the GP practices in the UK. So a really exciting partnership, because we hope to rapidly roll out to their organizations that they're supporting.
It's interesting because with physicians, we've always seen that when it comes to information technologies, normally the first approach is like rejection, like this is not really what I want. It consumes my time and so on. And it's a bit like if with generative AI, this kind of tools and devices like the one you're describing, they are so clearly useful and practical in reducing time and effort that I don't know, but I have the impression that for the first time we are going to see doctors actually wanting and being thankful for new technology. That there shouldn't be a lot of friction in the acceptance of this kind of project, right?
You're totally right, but I think that's because we understand it. We're the ones building it, and so for us, it feels sort of second nature. But one of the biggest challenges with implementing AI and technology more generally is one, the clarity. You said it's clear what the benefits are. Sometimes it's not always clear. Sometimes organizations aren't very good at articulating the value that they're actually bringing, even if they've spent loads of time on the product and lots of investment into it. Articulating the problem that they're solving and how they're solving it can be often a challenge. And speaking the language of the healthcare professional is something that a lot of businesses do really badly. So clarity is one hurdle that I think a lot of organizations, small businesses hit. The other is trust. Obviously, it's really hard to trust something that, on the face of it, is really clearly beneficial, right? We're going to automate your processes. We're going to take out the human. We're going to just make decisions for you. the market isn't there yet in terms of trusting someone to do that. And so we always look at, whenever we come to building a new solution, we say, well, there's a gap in the market, 100%. You should build this. But then is there a market in the gap? Are you going to be able to sell it? Because building something is one part of it and then selling it is the other part. So we're always really sort of focused on the horizon scan that our clients do. We actually test them and say, are you actually sure that the market is ready for what we're about to build for you? Because if it's not, you're going to be waiting a long time to get that into market. And we want them to get it into the market, right? Because we want them to be sustainable partners and clients. So that's
Yeah.
a really important piece. So the clarity and how you articulate the value, I think, is one of the challenges. Trust is one of the other challenges, and then change management, right? I mean, I think this is a global issue, but particularly in the UK, um, uh, every healthcare professional is busy. They always are working at capacity, and so for them to think about change has to be done in their own time, which they don't have, unless it's out of hours, which they don't want to do. So making that change process as frictionless as possible is super key. The saying is change occurs when the pain of staying the same is greater than the pain of change. So you basically have to make the pain of change less painful than their current job. And that's a really hard thing to do, but that's what we try and focus on.
Yeah, and it's one of the occasions where we're seeing this technological leap that is impressive enough so that maybe it's happening. This week, I was by chance in a social event with a manager of a private hospital here in Spain, and she was telling me something really surprising. I would have never expected to hear this so straightforward. She told me our generative AI tool for, in this case, not for summarizing, but for capturing the medical record, capturing the conversation and writing the medical record. So the scribe, our tool, it works so well that doctors are telling us they don't know what to do with their time. They're really free. I mean, it's really impressive that we're achieving this level of operational effectiveness so fast, right?
Right. That's pretty.
Okay. Okay, so I think that we had another project that the Bloom is involved into that we wanted to mention here today.
Yeah, for sure. We can slightly different AI project. Let's go for so we're working with a university in the UK on diabetic retinopathy. So we're using computer vision. Essentially the university has trained a model to look at a repository of, I think it's something crazy like 10 million retinal scans, and they've trained it to be able to recognize severity of disease for diabetic retinopathy. For those that don't know, global problem, comes with diabetes mellitus, or it comes as part of that if your diabetes is uncontrolled, and it can lead to blindness. So we have pretty good eye screening in the UK actually, but globally one of the big challenges is being able to recognize early disease and early prevention and screening. So what this project is doing is it's actually ranking disease on a list of the best, or normalize essentially, and really bad diabetic retinopathy, maculopathy, and then saying, well, this image is this bad out of all of these images. And when you rank disease like that, you're able to do some really clever stuff. You can obviously manage your budgets more effectively. You can start to, again, remove some of those administrative burdens. So that's a really interesting project because it's actually a different kind of model. Of course, it's looking at images as opposed to words and numbers, but it's at the same time stratifying that risk and being able to say, actually, we can hyper focus on this disease. We can be really kind of pinpoint on budgets and value and value for money. And then being able to, at the same time, again, make clinicians' lives more effective, get patients their diagnosis faster, and create a more cost-effective service. So yeah, that's a pretty cool project.
Yeah, I guess that images have great intensity of information, even more than words, and that's why this classification projects or diagnosis projects work really well in this area. And one of the things that strikes me the most is this idea that as you look at images that were in the first place created for diagnosing something very specific, in this case, diabetic retinopathy, and it can happen with other tests. The more data you put, the more it opens the possibility of even by machine learning techniques being able to infer diseases that apparently you wouldn't be able to predict with a fundoscopy if you were a human. But this ability of machines to go off target, to go opportunistic and look for farther conditions, I think that's a really impressive and counterintuitive and promising um, situation in the clinical setting. I don't know if this group is maybe thinking of going in this direction.
It's an interesting point, Ignacio, because there's benefits and there's risks to that, right? Incidental findings happen all the time, right? So if I am a doctor, and if I'm seeing someone in A&E as a prime example, if I'm treating that patient for their blood pressure, but I happen to see a mole that is, looks sort of abnormal, I could say to them, you're here for your blood pressure, but actually, I want to get that checked out. So incidental findings are everyday part of medicine, and some of them are life-saving. The problem is that not all of them are life-saving, and some of them can be distracting because actually it might be totally normal. So the example I gave you is a really good example of something that is life-saving. Actually, the mole might be more important than the blood pressure. But I agree. I think AI is going to be super intelligent when it comes to identifying sort of coincidental findings. But it's what we do with that information that's going to be super important, because if we refer everything, if we accept everything that is found coincidentally as we need to follow that up, we're going to overwhelm the bathtub. The bathtub is going to way overflow, right? Because the all of a sudden now it's saying this human came for one thing, an eye test, and they've got 10 problems that probably need investigating now. So great for the pay out your pocket healthcare system, but for the NHS, where every penny matters, that could be disastrous. So what I'm not saying is that we shouldn't be trying to find as many problems with patients as possible. It's that some problems are better managed elsewhere in the system, for example, the GP or the pharmacy or self-care, education. So we're going to be so rich with data because of AI, and that's such an exciting time, but it's what we do with that data that really matters.
Yeah, I totally agree that in medicine, sometimes knowing more can be less. We know that. I think Cochrane was the first one to really give us that idea, that concept that we've gone through many times, and that with AI, this is somehow going to explode. And I'm wondering how much the ones running the healthcare systems in Europe, especially, or the NHS, even the NHS, are ready for this situation of incidental findings, because it's growing more and more. We're seeing I remember this study from the UK Biobank where they were using densitometries for predicting who will have a hepatic steatosis. So something that is totally unrelated, but the machine can see there. And I think that we're going to see more and more this sort of target clinical situations grow, and it puts us at risk, because, as you said, even not only in terms of effectiveness, but also in terms of psychology for the patients. I mean, there are many questions that are opening right now, and another one is related not only to the ability of using tests for something unrelated or originally unrelated, but also for predicting the future. I don't know if you heard about this new test that is going to be able to predict with incredible accuracy who will have an Alzheimer's disease 20 years in advance. That's a bit of the same, right? A big challenge for the NHS when it's ready, which will happen in, I guess, 1 year from now, or maybe two.
Yeah, and we're straying into medical ethics now, which wasn't where I was thinking we might go, but it's a super important point, Ignacio, because telling someone that in 20 years' time they're at high risk of Alzheimer's, we need to understand, well, what can they do about that? Can they reduce down that risk, or is it inevitable? And that might be quite a scary thought for that patient. So the amount of counseling that would need to happen around that, and I think the point here is that the thing is, with technology, it's phenomenal, right? We're doing some really groundbreaking stuff across the board, not just Bloom. But it's all about context, because if I've got diabetes and you're reviewing my eye, just review my eye for diabetes, right? But if you're telling me that actually I can go shopping, you can scan my eye and you can tell me about my heart and my kidneys and my liver and my lungs, and just by scanning my eye, and it takes 5 minutes, it's non-invasive, it doesn't hurt, do it. I'll pay to do it because it's going to be better than having to go. So if it's for screening purposes, it feels right, right? But then is you know, where do we draw the line? Because if we do that on every eye ever, then, you know, we're going to be overwhelmed with coincidental findings and perhaps more screening than this current system can cope with. But screening is the way we need to go. Prevention is the way we need to go. So mapping out that plan, and I'm sure many of your listeners will know about the plan that the NHS or the UK government has set out here. That kind of forward planning is where we can say, right, we've got this groundbreaking Alzheimer's genomics test. But what do we do for those patients where we say, yeah, you're going to get Alzheimer's in 20 years? How do we give them healthy eating? How do we manage their exercise? How do we reduce down that risk? That's the important bit, because that's what a healthy population looks like.
Yeah, and talking of that predictive plan of the NHS and Foresight, the AI platform that will be able to predict, I think, 100 diseases, including chronic and rare and acute, even acute events, using the 56 million records from the UK. This once more puts us in a difficult situation once we start to get results. I'm sure someone planned for the amount of findings that this project may find. What can you tell us about it?
Yeah, well, I mean, the UK government has committed a significant investment into healthcare, and particularly technology and AI. So the future looks bright for that kind of change. Genomics, again, is another big part of that. You know, the UK sees itself as one of the industry leaders in genomics globally. So there's going to be big investments coming down the road. I guess for small businesses, what does that mean? I think that's still to be defined. I think the next 5-10 years will be very exciting in terms of where we might go as a country, and how we can impact not just on the NHS in the UK, but internationally. You know, there's a lot of international impact that we have of innovation here. So the UK is actually a really great place to be innovating, because you get to work with the NHS, you get to work with the private sector, you get to work with the academics and the pharmaceutical companies that are based here or have a big presence here, and the world looks at that. So yeah, I think there's going to be, perhaps during this transition phase, often there's a lot of uncertainty, and that can often lead to slowness in terms of decision making and opportunities for small businesses. So that's tough. But I think once we get through that, and it's really clear what the plan is and where the funded opportunities are, I think it's going to be a great opportunity for businesses in the UK, and academics and charities and non-for-profits as well.
Yeah, so going a bit into that direction, you as Blüm are helping us, Savannah, to work with the healthcare providers in the NHS, and to understand how the system works. One of the things that we are seeing that is gaining importance is the way in which you handle data, how it's transferred from one place to another, how trust is generated around data governance. Then we have these secure data environments. So how do you see the landscape evolving in this regard? Are you positive that the sharing of data is something that will be a reality in the UK, or we're going more in a direction where it's more, on-prem based, less cloud, more protective? How does it relate to its competitor, which would be the European health data space?
Yeah, it's a really good question. So I think we're going to be moving in the right direction. You know, the NHS has always generated lots of data. I mean, the UK healthcare industry more widely has generated loads of data, and actually, comparatively speaking, the amount of data that's available for things like research and innovation is way more than a lot of the countries across the world. You know, the NHS has actually done a really good job at making data available for research purposes and innovation purposes. The problem is the quality of it. So often, in times gone by, the quality of the data can be quite variable. I think part of that is the nature of medical notes is it's unstructured. It can be often quite fragmented. The availability from an interoperability perspective, the way that data has been managed historically has been quite isolated. You know, if I go on holiday to the south of the UK, they won't be able to see my medical record currently. And that shouldn't happen, right? In a national healthcare system, it should be democratized and it should be delocalized. The quality, the availability, and then the availability. The quality, the interoperability, and the availability, as in the availability of how we as researchers and innovators access it. So you've mentioned a couple of things there, like the secure data environments, a really clear gateway to be able to access high quality data safely, securely, and with permission. So these are a great initiative. It's an easy way to be able to do that. NHS app, a way for patients to be able to access more data, and in turn, obviously, we can engage with patients more freely through things like the NHS app. We have a federated data platform, which is essentially trying to delocalize a lot of the data that is stored around patients, so that more data can move with the patient than with the institutions. That's quite well. It's been around for a couple of years now, but it's a long-term project. There's still a lot to be realized there, but there's some quite interesting projects going on with the FDP at the moment. So I think the government is well aware that it has a national healthcare service, and to try and nationalize a lot of the data within it is a key priority. So that's what the three initiatives I mentioned there, around the delocalization of data, the access for patients at the NHS app level, and these are part of the 10-year plan. So that should become more available to organizations like Savannah Med, that actually is taking that data, creating really useful and meaningful insights from it, and then being able to in turn support patients and the hospitals that you're working with. So I think for you, that's only going to get easier as we see more high quality, more readily available data available.
That's great news. My team will be very happy to hear this. So that's talking about regulation, which touches data and privacy, which is more related to what we do. But what about the other part, the getting the stamp when you have an algorithm, an AI algorithm, and you want to get the certification to be able to use it in clinical practice? What would be the US, the FDA approval, or in Europe, that would be the medical device regulation. So what is the equivalent in the UK, and how tough it is to get this kind of certification compared to its peers?
Well, if you ask a lot of the regulatory advisors, they would probably say that UKCA is comparatively similar to the CE, perhaps a little bit easier.
Okay.
A lot of people feel that strategically they're better off growing a medical device in the UK because the UKCA mark perhaps is easier to achieve. I think that's not going to be the case for long. The UK MHRA, which is the governing body, the same as the FDA, is more closely aligning itself to CE marking, and by default, I guess, therefore FDA, which is going to mean that the regulation is going to be a little bit tighter. I think the class of devices is going to be a little bit more strict. At the moment, class 1 is a self-certification process. I think it's going to be a lot harder to self-certify. Maybe there won't be an opportunity to self-certify going forward. So the landscape in the UK is changing. Now is a good opportunity to start that regulatory journey here in the UK whilst it is in that transition phase, because, to me, owning a manufacturing business that builds software products, we always advise, the beauty of software is that the product can go through an evolutionary journey and can take on more of these responsibilities as a medical device. So it can start as software as a service, it can grow to be software as a medical device, and then it can grow to be AI as a medical device. And you've almost got this curve of risk and speed to market, whereby as you evolve your product into that, it takes longer to get to market, it costs more, and there's higher risk. So the adoption barriers go up, right? So by getting an early solution into the market that provides enough value, then starting to think about how you demonstrate clinical evidence, you start to automate processes, you start to implement logic and AI into it. You build trust with the clients that are already using it, which is great. You gather evidence clinically, which is going to be important for your registration. Obviously, you get your processes down because you're already out there. So that just feels like a more natural progression. But I appreciate that some organizations just go, I want to be able to automate this thing, and it's going to be a class 2 or 3 medical device. So what am I saying? I'm saying that I think the UK is a great place to innovate, because even though the hurdles are there, the hurdles for a lot of people that I've spoke to feel lower than when they've then gone to do CE marking and FDA marking. But I would say that for any organization starting out now, they need to have a really clear regulatory strategy that includes international standards, because I think we're going to be essentially aligned to them, if not the same as them, in the years to come.
Okay, so we're following a workflow here in this conversation. We started with what is doable, what is possible, like for example, the diabetic retinopathy. We skipped the editorial part of it. We assumed that this gets into actual peer-reviewed publications because it works. And then we went into the regulation, and now if you have it and it works and it's certified and approved, you have to make sure that people use it. It's the implementation part, which is so difficult because many times we have algorithms and we have scales and we just don't use them. It's part of it. It's part of the history of medicine. And many people tell me, why should this change just because it's made with AI? The problem of underusing the resources may be still in place. And I'm I remember that we met at you and I we met at this health conference in Amsterdam, I think last year, and I remember that there was a CEO of one of the big hospitals in the UK. I don't know if it was Imperial or Guy's. I think it was Guy's, and he was telling us about this sort of platform by which all the algorithms of the country will be able to be somehow downloaded, or that it was intended to have to give access to the professionals. So there's something like a central hub where we're going to be sure that the AI can get access and use and monitor. I don't know if you can give us information, because obviously the UK has done good progress in this regard about how to handle this last mile problem, which is always a big problem.
Yeah, I mean, I can't talk specifically about what it might have been Ian that mentioned that, the CEO of Guys, because he was there. And I'm not sure what platform he might have been speaking about. It kind of sounds like the federated data platform that I mentioned before, which is trying
I
to
think so.
yeah, that's essentially trying to create that centralized data repository, but also you can build products and you can build innovations onto it as well. So that perhaps sounds the closest thing to what you're describing there, Inacio. But ultimately, implementation is everything, right? If something's not being used, it's for an option of reasons. One, because they don't know how to use it, so training and in education. If there's not effective training and education, not just the first time, right? Because everyone just clicks through the training, no one actually does it properly. There needs to be continuous training and continuous how to. That will make it more adoptable. If it's not being used because it's not valuable, well, you shouldn't have been bought in the first place. So that's one of the challenges. If people are saying, I don't use it because I don't need to use it, then you've got lucky with someone buying the system that never needed it in the first place. So then you have to go back to your value proposition of why you're doing what you're doing and how you're articulating that, because perhaps it is valuable, they just haven't realized why, or perhaps it's not valuable and you're not doing very well. The the companies that we see do well have at least 30-40% of their revenue come from referrals, right? This is not a healthcare specific thing. This is a generic MBA thing. If you're having to advertise and spend loads of money on SEO and LinkedIn ads, the product's not good enough. You should be having 30-40% of your revenue coming through referrals, because that means people are talking about it. People like it. They see value in it. They want other people to benefit from it. And that's critical. So the implementation is really important. Making it as easy as possible to adapt. That comes back to the change thing. Making sure the value is really realized, and then providing that extra layer of support continuously, because we do need hand-holding as healthcare professionals. As I say, we're busy all the time. We do need support in making that change as easy as possible. And that doesn't just happen before the contracting and the training and the go live. It happens for the years after that as well, because we're going to want changes to the system. We're going to want new things from the system. And by providing that support service, people just like you and they'll talk about you, and then other people will want to use you.
Michael, you don't have to take this last one if you don't want to, but I assume that you're in a great position because you are exposed to many companies that are trying to innovate and to bring interesting stuff into the healthcare system. So I am wondering if you can tell us about, a wild card, some disruption, some technology that you think that within 5 years is really going to surprise us, while everybody's looking at, the usual predictive algorithms and generative AI. Is there anything you've seen in the landscape, maybe from Asia, maybe from the US, maybe internally in the UK that that you think that is worth mentioning?
So I think someone asked me, a colleague friend of ours asked a question the other day that says, what comes after the electronic patient record? Um, because inevitably evolution will say that EPRs as we know them, EHRs, EMRs, as we know them, are revolutionary, right? They've taken paper notes, they've pretty much done away with them, and you can have all of that information in one place. What's the next step after that? Where can we get to whereby you haven't got the monolithic EPRs, the sort of big, chunky pieces of software that manage flow operationally through a hospital? What is better than that, And I think that's one of the things that is really quite exciting. And one of the things that we've started to scratch our heads at Blüm about is actually how do we democratize that process? How do we create like a blended ecosystem where actually you get the best of every system all together? It's accessible, it's the best of you could pick which systems you want, it's almost modularized, it's democratized, you're not locked into specific vendors, you get the best value for money, you can choose what you spend on it. So that's something that we're trying to crack now. Just and it's going to take years, and EPRs are going to be around for as long as we probably know. But thinking about what comes after the EPR someone's got to start doing it, right? So that's what we're looking at the moment, which is quite a where do you start? Is quite a blue sky thinking project, but it's important to start to think about the evolution of healthcare as we know it, and it's exciting.
It was great talking to you, learning from you. Thank you very much.
Thanks, Ignacio.